Thank you for your patience. Okay, so I'm an internal medicine consultant and I work with the KPH medicine department. I'm also assistant associate lecturer with the University of the West Indies, as well as I'm an honorary consultant at the University Hospital of the West Indies. I have special training in stroke program development, and so stroke is my passion. Stroke care and prevention is my passion. All right. I'm not going to go through a lot of, well, I'm going to quickly go through some foundation stuff that you guys should know already. And then we're going to go into some questions because I know you guys have questions. I didn't see any raised hands. Yeah, I didn't see any raised hands. So we'll just go into this. Two types of stroke: hemorrhagic ischemic stroke, where ischemic stroke is around 80% of all stroke presentations. And hemorrhagic stroke can occur in the basal ganglia area here, and it can be, the etiology can be multifactorial. There is aneurysm can rupture. You can have a plaque for ischemic stroke, and then this ruptures, and then a whole clot occludes the whole artery here. This is for ischemic stroke. And then for embolic stroke that leads to ischemic stroke, the clot comes from a distant source, travels up the intracranial arteries, and then you have an occlusion, all right? And then you get your stroke. And you can have hemorrhagic stroke from either rupture aneurysm, or because there is hypertension, changes to the very small blood vessels within the parenchyma of the brain, especially in the lacunar area here, the basal ganglia area here, you can have a hemorrhagic stroke. When you have a stroke, you want to divide it into two main localities. Is it an anterior stroke, where the anterior division of the internal carotid goes and divides into the middle cerebral artery here, or the anterior cerebral artery, and this is called anterior circulation stroke. And then at the posterior circulation stroke, you have the vertebral arteries joined together with the basilar artery, and then they divide, they make this T shape to create posterior cerebral arteries and the posterior communicating artery. Anything in this area is considered posterior circulation stroke. I'm not going to go into stroke syndromes, but basically anterior cerebral artery stroke or anterior has specific presentation. They tend to be unconscious, very poorly responsive. You can have mood changes. With the middle cerebral stroke, you can have the Broca aphasia, expressive aphasia, and then limbs are involved with the middle cerebral stroke. Now, always remember an acute onset of loss of balance, that's a posterior circulation stroke. All right. So we tend to divide stroke into localities so you have an idea of what artery may have been blocked. And this is very particularly important when you know the syndrome for middle cerebral arteries, how they present versus anterior cerebral artery versus posterior. Because if patient is a candidate for thrombectomy, it gives you an idea of that's a large vessel stroke, and therefore they'll be a candidate for thrombectomy. All right. So what is thrombectomy? So there are different ways of treating modalities to treat stroke nowadays to meant to restore perfusion to the brain. I want to look at that next with you. Between 0 to 3-6 hours, we have clot busters, and that is for our thrombotic or ischemic stroke that we're going to be looking at how we manage ischemic stroke. Between 0 to 3 hours, if the patient is a candidate of thrombolysis, we give thrombolysis. If they're beyond 3 hours, between 3 to 4.5 hours, the category of people who do well with a thrombolytic or what we call alteplase or tenecteplase, and the brand names are Metalize is basically what we have in Jamaica, and most ERs in Jamaica. It's Metalize, and it's the same thing we use for MI to open up the coronary arches. It's the same thing we call fibrinolysis. All right, these are the clot busters, and so they break down the clot. They work very quickly, and it's important to get reperfusion done quickly so you can save as much brain as possible. Because 1 minute after every stroke, you lose 1 million brain cells. So time is brain. Time is brain. All right. So from the last normal or the last time the person was seen at baseline, and then you have the onset of the neurological symptoms, if you can get them into hospital between the 0 to 3 hours, they can be a candidate for clot busting drugs. And there are some eligibility criteria that you will go through with that. If there's beyond 3 hours, there's a small sample group that can do well between 3 and 4.5 hours. And those who are not in that group, anybody knows? Who do you not thrombolize after 3 hours? Anybody knows? After a person presents after 3 hours and they have this condition, they are not a candidate for thrombolysis. I know off the bat. Anybody? I see in the chat someone has said if a person has AFib. Thank you for trying, Gabe. Thank you. Anybody else? If a patient is diabetic, they can't get thrombolysis after 3 hours of last known normal or at baseline. Right? Because what they found in those studies, diabetics, they bled on you. Good try, Hydol. Good try. Avon, that would be a lot bigger than the exclusion criteria I'm talking about, between the 3.5, between the 3 and the 4.5. But definitely for patients that bleed, you can't give them thrombolysis. So that's great, Alan. That's the first step. But between 3.5, between 3 and 4.5, if the patient is diabetic, if they're over the age of 80, and if they have a large stroke, a stroke with a NIH stroke scale greater than 25. That means a lot of brain has been involved. And if you damage cells are leaky cells, and therefore leaky cells will bleed, will hemorrhage on you. So that's why they don't give thrombolysis to those people with large strokes over the age of 80 and are diabetic. All right. Thanks so much, guys, for trying. Great, great, great. So I'm going to back up again now. Oh, so then if you are not any of these and you are between 3 and 24 hours, this is a new thing that's come up in the last 3 years. We have what we call stent retriever thrombectomy, which is mechanical thrombectomy. They pass a guide wire, and this goes straight into the clot, embeds itself in the clot, and then you can pull the clot right out of that vessel and restore flow. And if the patient has good perfusion scan, what we call a rapid, or when you do their perfusion scan, that you can get good restoration of brain. After you try this, then the person will be eligible for mechanical thrombectomy. So it's a person who fits a certain criteria can get mechanical thrombectomy, and it's usually after a perfusion scan that that person can get the mechanical thrombectomy, right? And they do very well. They have people who they come into the ER within 25 minutes. They get their CT. There's no hemorrhage. We check the eligibility criteria for alteplase or thrombolytic therapy. They meet the criteria. They get the thrombolytic therapy, and then they go on to get angiogram to find out where the blockage is. So a CT angiogram is done after the original non-contrast CT. And then they find the blockage, and then they transport the patient to mechanical thrombectomy. And then they pull that out because they find the blockages in an artery they can get to with the stent retriever. All right. So here is an algorithm from Target Stroke Guidelines, which is what every stroke organization across the globe has adopted. The time from when the patient hits the ER room to the time when we can give thrombolytic therapy should be less than 60 minutes. And in the America and some parts of Europe, they're getting there where they're some places in the US, they're less than 25 minutes. It's like they come from the ambulance straight onto the table, on their way between the table, they are weighed, the medical team assesses them, does the NIHS score, and then they get their scan, and then they get that thrombolytic therapy right within that 25 minutes. So it's possible. But at least in Jamaica, we're praying that we can get people to CT within 30 minutes of arrival. That's what we're trying to do. That's our first aim. And I think it's possible if everybody from the porter, the ambulance driver, to the nurses and doctors work together with pharmacy to get, and the radiology to get the patient in and scanned, and then have the thrombolytic therapy available. All right. So first, before you get here, you have to recognize the patient needs to go to hospital. And how do we do that? That's where the acronym BFAST comes in. And this is what we want to tell everybody in Jamaica and across the globe. Be fast, because time is brain. And BFAST is an acronym of the symptoms of a stroke. So sudden loss of balance, sudden loss of eyes, vision in one eye or both eyes, drooping on one side of the face or numbness on one side of the face, and then arms, A is for arms, but I want you to extend it to limbs. So it's upper and lower limbs. And is there weakness in either one of them or both? And then speech loss or difficulty speaking or not able to speak at all. That person may have a stroke and they need to call 911 in the States. But here in Jamaica, we do not have a national ambulance service, so you do not call 911. You call the nearest relative or a taxi driver. Do not let the person drive themselves, and that person gets them to the hospital room. So they reach the hospital room, the ER, and we see this person. Okay, this person is who? Who should see the patient at 10 minutes upon arrival? Anybody can guess. Who's that this little person here? Who is this? Are you able to see the screen? Somebody tell me.
Is a doctor or nurse, triage?
Triage nurse. Who responded? Who was that?
Malahanda.
Very good, Malahanda. You've been in the ER. Very good. All right, Vassal, type out to me if you were the triage doctor, right? What sort of things should your triage nurse report to you? They're going to do some stuff. What are they going to do? BP. More stuff. They can't just give you the BP alone. Glucose. All right, anybody else can respond now. What else we need in there? No, Janoi. We don't want the UA right now. Thank you, though. Shani, I want specific. Very good. I see O2 sat, pulse ox, GCS. I see heart rate, blood pressure. Yes, these are the things that nurse can do within 10 minutes. All right, UA may take a little longer. It doesn't really change our management much. Thank you, though, Janoi. All right, everybody else who has responded, thank you so much. And these are what we're going to start with, vitals, because vitals are vitals for a reason. So, Vassal, tell me now, what would be concerning in the O2 stat for you? Yeah, I'm asking a real simple question. Yeah, real simple. What would be concerning? What would, if the nurse tell you this, you're like, oh, we got to do this. Oh, that's all right, nurse. The patient's okay. Yes, Vassal, what are your parameters? All right. Maharaj says less than 95 on room air. I see sources 92%. Definitely, if you have a COPD, a patient with previous smoking history, yeah, 92 or less would make me more anxious, not above 92. But if you don't have that history, all right, I will give it to you less than 95. But my aim here is that you must recognize you're looking out for hypoxia for everybody, the 182 of us that are here. Look out for hypoxia because hypoxia will mimic stroke. And what do we treat hypoxia with? Everybody gets this. Everybody, 185, but you must oxygen. Thank you. You put the patient on oxygen. So I say yes. If you see a patient with an O2 sat less than 93, 94%, please go ahead and put them on oxygen. The aim is once they're between 92 and 100% on oxygen, we're okay with that. We don't want too much oxygen as well because we don't know if they're COPD. So if they're 92, 93, you want to give them a little oxygen, a 1 liter, 2 liter, but you don't want them more than, too much oxygen, right? Okay, now next thing, pulse. No, let's go back to BP. Someone had responded BP first. Pastor, did I ask you all these questions already? Let me choose somebody. Hewitt, I see you responded pulse. What would concern you, Hewitt, with the pulse? What's normal? What's abnormal? Hewitt, pulse. Right. Yeah, we tend to expect it to be around 80 to 100 to be okay. Less than 60 is bradycardia, right? Okay, I see someone had put in respiratory rate, all right? Remember now in Jamaica, most nurses say 18 and 20 is normal respiratory rate, but the McLeods or the other textbooks say, anything above 18 is concerning. But if it's at 20, it may be normal. It may be normal for our Caribbean setting because we're like counting 15 seconds and then times by 4. But if it's 24, 26, getting close to 30, this is moderate to, moderate respiratory distress. And anything above 30 is probably severe respiratory distress. All right, that patient will tire on you and stop breathing, and that person will die. So just to be wary of that. Okay, what other stroke mimics are out there? I saw someone mention glucose because hypoglycemia is a very common stroke mimic. You give them the sugar and they get better. So it's important to do vitals. That's why vitals are important. So blood pressure, pulse, O2 sat, respiratory rate, as well as the glucose are the things that you need from your triage nurse. So you gave that. Now it's your turn. It's now your turn to do your assessment. And so you quickly assess the patient. When was the last they were normal? What are their medications that they're on? Right? These are your quick questions for a patient with stroke. All right, and then you're going to do the NIHS Health Stroke Scale Score. Why is that? Because that's going to be your universal language with anybody talking about stroke. How bad is the deficit? And so National Institute of Health Stroke Scale is what we use, and it has 11 parameters to it. Consciousness, orientation, response to commands, gaze, visual fields, and facial asymmetry or facial weakness, right? And then motor function of the upper arm and the lower arm, limitaxia, sensory, language, articulation, and extinction and inattention. Just to let you know, extinction and inattention happens with parietal stroke syndrome. Just give you that little tidbit there. All right. And yes, GCS is important because low GCS also makes the patient high likely of mortality and morbidity. And with the NIH score, it also gives us stroke severity. So 0 to 4 is minor stroke, 21 to 42 is considered a severe stroke. And they have poor outcomes, really poor outcomes, right? Just to let you guys know about that. So let's go back into our triage room. You've done the NIHS score. You've notified the stroke team, which would technically be the medical resident on call. And then they and you will take the patient onto a CT room. And as someone had mentioned, in the CT room, we're going to do a CT to make sure there's no bleed. But what kind of CT we're going to do? Anybody in the chat can respond or verbally. What kind of
CT without contrast?
Without contrast. Very important, without contrast. All right. One, because we don't have the UNEs and the creatinine. No, we're not going to do that. We're going to scan them right away. So we're not going to wait on labs to scan a patient. Question to the group. Question to the group. The scan is normal. The patient is eligible for thrombolytic therapy within the 3-hour window. Are you going to wait for the labs then? Assuming it's ischemic stroke, start thrombolytic therapy. Maharaj says, and I believe Manahan is talking about, no, we don't wait. Yes, I agree with you, Smith. We don't wait. We go ahead and give thrombolytic therapy. The only drawback I would say to wait for is if a patient has, and someone had mentioned it earlier in the chat. Let me ask them. All right, there is no contraindications to TPA, but we're going to wait for labs in this person. Chris Gale, Chris Gale, why are we going to wait for labs in your person? You had mentioned it at 4:45 p.m. in the chat. If the patient has, Chris Gale said it. Huh?
That's the AFib fib?
Yeah, if the patient has AFib and they're on anticoagulation, sorry. They're already on anticoagulation, then maybe you want to wait on the labs before you give a thrombolytic therapy. Only those people, you would probably wait. All right? If the patient's on aspirin before, you can go ahead and give thrombolytic therapy if they're eligible. Right? So it's only the anticoagulation. People are already on anticoagulation that we may wait for labs. Other than that, go ahead and give thrombolytic therapy if they are within the window and eligible. All right, so I want to talk about stroke mimics. We had mentioned hypoglycemia is one, and you put into chat what other stroke mimics that you know out there. Since I think, yeah, if the patient is known thrombocytopenia, but let's say we don't know the patient is thrombocytopenic, we're gonna go ahead and probably give the thrombolytic therapy anyways. All right, because we're not waiting for labs. The only person waiting for labs is the person on anticoagulation. Seizures. All right, any bright spark out there can tell me what kind of seizures? Not Marcelina. Todd's paralysis. Very good, very good. Okay, so Todd's paralysis can be a stroke mimic. Hemiplegic migraine can be a stroke mimic. How do you know the difference? Here's Janai. Last. Mr. Jax. We're gonna do that last. That is like a diagnosis of exclusion. You always give your patient the benefit of the doubt. So for the hemiplegic migraine, they tend to begin like a migraine. They have a headache first, right? They have a headache first. They describe aura with their headache. And then they have the onset of deficit in the arms or the legs or both. All right, very good, guys. All right, what else? This patient has space occupying lesions. Can mimic very, very good. Very, very good. Bell's palsy. I tell you, we see it a lot in the outpatient department, in the clinics. You're going to see it and you're like, is this a stroke? But what's the difference between Bell's palsy and an upper motor neuron deficit? Anybody? Total facial paralysis. Fantastic. Frontal sparing, forehead sparing, eyebrow sparing. Excellent. Excellent, guys. Very good. Very good. So that's how you can differentiate a Bell's palsy from an upper motor neuron lesion, which is a stroke, a brain lesion. They will be frontal sparing with the brain lesion. All right. If the patient had Bell's palsy first and then come with a stroke, I don't know. But majority of them won't do that to you. Okay, guys? We won't even give that in the OSCE. All right. But yeah, that's how we differentiate the stroke from the Bell's palsy. And lots of people come in the ER and they're like, I don't know. Is that we'll just check the forehead, the forehead spare. Very good, guys. Very good. Okay. Back to stroke mimics. I see you guys put uremic encephalopathy. They have depressed sensorium loss, depressed responsiveness. They are delirious, but there's not really a focal lesion there. So not usually. A TIA is considered a stroke. All right, because technically they had the same etiology. There's an occlusion. It's just that the occlusion cleared quickly. But that person is not the person that we do not investigate. I want you to treat all your TIAs like stroke. We need to prevent them coming in with a full-blown stroke. Why did they clot? Why did they lose perfusion? For a TIA, that's what I want you to ask yourselves. And so the same stroke workup is the same stroke workup for a TIA that we must do. All right. Every TIA is a way to prevent a full-blown stroke. All right. So we're gonna look at the they call it workup of stroke in a little bit soon. We're still on stroke mimics. So I agree with you guys so far. I'm gonna give you my listing. I just wanted to give you one more situation and get your response. This is a patient who is 45 years of age, has hyperlipidemia, and is on high heart therapy, antiretroviral therapy. And they are coming out with depressive sensorium. There is loss of power, both 4 in the upper limb, 4 in the lower limb on the right side, upper and lower right-sided limbs. What are you gonna think here? Meningitis. Not the thing I'm looking for, but close. PML. Yeah, possibly. Toxo. Who said toxo? CNS abscess. Oof. All right, let me ask a person with the toxin something, because that's what I was looking for. Who said toxo? Melville, how are you going to find the toxo now? What are you going to order next? It could be a lymphoma, I agree, but this is sudden onset. Lymphoma is possible, I agree with you. CNS abscess, I agree with you. CNS tumor, I agree with you. Maraj says CT brain or MRI. MRI machine doesn't exist at KPH. What can I order? Dinville, what kind of CT? Ooh, Heidel, correct. CT with contrast for ring enhancing lesions is pathologic. So excellent, excellent. Guys, don't forget that. Don't forget that. All right, let me look into my list for stroke mimics. So we've covered migraine with aura, hemiplegic migraine, which is also called complicated migraine, seizures. All right. We looked at we didn't look at it, but someone I mentioned uremic encephalopathy, more like hypertensive encephalopathy. They can present with delirium, high blood pressure, which we also see in stroke. All right, Wernicke's encephalopathy. Someone had mentioned alcohol intoxication. It's more, they have the ataxia, the ophthalmia, and is it Wernicke's encephalopathy for that kind of patient with the alcohol on board? All right, CNS abscess you guys mentioned, CNS infection with toxo we had mentioned, CNS tumors, you guys have got lymphoma, even people who have a primary like breast and prostate or lung cancer, and it's metastasized to the brain, sudden onset of weakness in those people, you want to try and get your CT and confirm is it a tumor or not. And then some drugs can mimic stroke, lithium, phenytoin, and carbamazepine in toxicity. All right. So the patient had the CT, had none of those. They got the thrombolytic. If they have a large vessel occlusion and their perfusion scan was good, we could probably consider thrombectomy as well. All right. So patient gets to the ward. Patient gets to the ward. Patient gets to the ward. How you manage them. And part of that is management of the blood pressure. For ischemic stroke, we want to make sure that they have good cerebral blood pressure. And so we don't want to lower the blood pressure too quickly. And so within the first 48 hours, we have some permissive hypertension. But after 48 hours, they should correct themselves. If not, then you need to help maintain their blood pressure at a normal level, because by 48 hours, their blood pressure should come back to normal. So you can start a low dose high blood pressure medication. Notice I said after 48 hours. After 48 hours. And it's low dose. You don't want to drop it too quickly. But why am I saying after 48 hours? Because by day 3, 4, we're thinking about discharge preparation. We're not sending them home on no blood pressure medication and their blood pressure is high. Can't send them home with blood pressures that are high. They should, by 48 hours, start to have normal pressures being recorded by the nursing staff. All people with stroke should go home on a statin therapy for MI, statin therapy for stroke. Nobody wants to talk to me. Can someone talk to me? Tell me why we like statins. I heard one doctor say we should put it in the water supply. It's that good. Right, so the map of one greater than 120 is in the first 48 hours. But after 48 hours, we want normal blood pressures, all right? Normal pressures. So I usually say between 150 and 180 between the first 48 hours. After 48 hours, I come on my run at 72 hours, it's day 3, and the blood pressure is 160. I would say go ahead and start a low dose ACE inhibitor. I tend to start with this. I don't drop the blood pressure too quickly, and they're pretty good otherwise. All right. Once they're not allergic to it. So the question is, why do we like statins? Anybody knows? It's called the pleomorphic effect of statins. They cause, go ahead.
I was going to ask if that's because it helps to stabilize the atherosclerotic plaque and prevents like a embolic event.
Right. So they theorize it. They call it pleomorphic because we're not exactly sure how they work. But they theorize that they reduce endothelial dysfunction. And that may be at the microscopic level anti-inflammatory. Yeah, someone mentioned anti-inflammatory. The term is actually reduced endothelial dysfunction, because endothelial cells, when they are inflamed, they put out receptors that make the platelets get attracted to the endothelium, the lining of the vessels, and sticky platelets causes a sticky reaction, and everybody joins in the party, and then sticky platelets make thrombus, which are clots, and then you get your stroke or your MI in the coronaries if the thrombus forms in the coronaries. So that's why we love statin therapy. So even if the lipids are normal, everybody please remember this, they must go home on statins. Even when the lipids are normal, they come back normal lipid profile, they must go home on statin, high dose statins, all right? High dose, high potent statins, just like for your MI. All right, so that's your atorvastatin 80, your rovastatin 40, all right, those tend to be the highest potency statins. All right, moving for measure for stroke. I'm coming. It's almost 15. These core measures are core measures that you need to institute when you are on the ward. The patient, if they are on thrombolytic therapy, they should be on one-to-one nursing, vitals every hour. They should have a follow-up CT after 24 hours, because we want to make sure they didn't have any bleed after you give them the thrombolytic therapy. If they develop a sudden onset headache after giving them thrombolysis, if they have any change in their neurological deficit, they also should get a repeat CT same time as well. All right. Now, Bianca, you have a great question. Do I give BP medications before 48 hours? Yes. The scenario is hypertensive emergence. Hypertensive emergency. The patient has end organ damage with a systolic blood pressures greater than 185. Yes, you will give BP medications. Bianca, can you tell me what kind of meds you would want to give that patient who is in hypertensive emergency and organ damage with systolic blood pressures greater than 185? They usually come in like 245, 230 systolics. You can't let them stay like that. All right, please treat them. If Bianca cannot find a med, somebody suggest a med. What meds are we gonna give? Hydralazine is not my first choice, James. Labetalol is. Why labetalol? Because you can titrate it. It is short-acting IV medications for hypertensive emergencies. Very good, Ramsey. Nitroprusside is one option. Well, labetalol is my first option. And labetalol, you can give like, I have to look up the dosages. But you can give a small dose, recheck the blood pressure in 15 minutes. You should see a response. And the aim is to bring the blood pressure to less than 180. Or within the first hour, to drop the blood pressure within 20% reduction of what first the patient came in. No greater than 20%, because studies have shown that more than 20% reduction will reduce cerebral perfusion in a stroke. So you do not reduce the blood pressure more than the first hour. And then you can try. You can try labetalol. If you don't have labetalol, nicardipine is my second option. Not very frequently available, but that's the other one that guidelines recommend. Nitroprusside, you have to watch it out. Watch out for nitroprusside because it has a side effect. What can it be, Ramsey, you know? You can use it, but what can it cause? What is HOTM, Ramsey? Cyanide toxicity. Very good, very good. You know also what's good out there? And you're gonna see it, GTN infusion. That's exactly where I was going to. GTN infusion. Now remember with the GTN infusion, guys, you must wrap the tubing. There's a reason why GTN is, I think it's stored in the fridge or it's in a closed compartment. It's exposed to light, it reduces its effectiveness. So you must wrap the tubing when you're going to go with nitroglycerin infusion for your hypertensive emergency management. Excellent, guy. Excellent. All right. So Alan, 20 no greater than 25% is also there, but I saw in another literature somewhere, no greater than 20%. So I would stick with 10%. You don't want to be too much. Just basically no more than 20%. The role of diffusion, MRI. Listen, man, Jax, we don't have no MRI. MRI is not in this talk today. All right, it's at the end of the talk. It's not going to change our management. All right, let's go back now to stroke core measures. BP management is one, statin therapy is one, and deep vein thrombosis prophylaxis. Why? Because PE is a major killer of our immobilized stroke patients. And now we're going to touch on hemorrhagic stroke. Again, with hemorrhagic stroke, we do not want to drop the cerebral perfusion, but we don't want them to be high because the more high blood pressure, the more the blood is going to be going into the brain. And then you get compression and then herniation. So we don't want that. So we want BP management with our hemorrhagic stroke. As I said, you want to keep it less than 180 systolic and around 150 systolic, so that you don't drop the cerebral perfusion. So hemorrhagic stroke, how do we do DVT prophylaxis with those people? Because they can get PE too. permissive hypertension, Mullins, just to clarify, means within the first 24 to 48 hours, you try to keep the BP less than 180 or greater than 150 systolic to maintain that cerebral perfusion. Just for that reminder, to clarify that for you guys. All right, we're back to, I had asked that question a while ago. Hemorrhagic stroke, how are we going to prevent DVT in the compression socks? You mean pneumatic compression devices, right, Smith? Yes, Campbell, pneumatic compression devices. Very good. All right, they're not in stock. You prescribe it and get the prescription to the family and say, listen, this is going to prevent DVT and then clot going up in the lungs and killing your relative. Please, can you try it? Otherwise, for hemorrhagic stroke, those are the only things that are proven to prevent clot, not graduated compression stockings, not graduated compression stockings. And of course, you're not going to give them heparin. All right. They should be discharged on antithrombotics. Antithrombotics means clopidogrel or aspirin. Clopidogrel or aspirin. Now, they are from the POINT trial and the CHANCE trial, a subgroup of people who have, note what I'm saying, a small stroke, a very low NIHS score, less than 4. And usually in these studies, they had intracranial vessel imaging. Basically, they had CT angiogram of the head and neck. So they were going to have intracranial atherosclerosis. That subset of people that have intracranial atherosclerosis, very minor stroke, or TIA, those people could benefit from a short, notice the big word, short course of aspirin with Plavix. If you remember, everybody who has an MI gets aspirin and Plavix, but with a stroke, not. It's a subgroup. People who have TIA, minor stroke, with intracranial athero, they get a short course of dual antiplatelet therapy. What's a short course? Less than 21 days. Why? Because beyond 21 days, people with stroke on dual antiplatelet therapy will bleed on you. They bleed right in their brains. Okay? So don't do it. So if you see a patient, they had a stroke, someone sent them home on aspirin and Plavix, you're seeing them 6 months, 3 months later, and they're still on the aspirin and the Plavix, and they don't have coronary artery disease, please stop one of them, because the patient will bleed on us. All right? Anybody with a question with that? Patient must go on one antiplatelet. If you get anything, just get this. Patient must go home on statin. Patient must go on aspirin. 81 milligrams is just as good as 325. And 325 come with more bleeding risk. So go with aspirin 81. Aspirin is cheap, and everywhere you can get aspirin. So that's why we go with aspirin, 81 milligrams, and statin when a patient is discharged. Notice this is called discharge core measure. All right, everybody must have antithrombotics to prevent stroke and statin. Any question? Aspirin and Plavix for 21 days for minor stroke TIAs with intracranial atherosclerosis, Gail. Aspirin can be lifelong to prevent stroke. Aspirin lifelong, 81, just aspirin, single use aspirin. All right, or Plavix only if you want to go with Plavix, but not together for lifelong. Never long, no more than 21 days for aspirin with Plavix. No more than 21 days for aspirin with Plavix. That will increase their bleeding risk. High dose aspirin, we don't do it in stroke, only in MI. You can give 325 for 81 is just as good. So you can just give 81 milligrams with statin for a person who hasn't gotten thrombolytic therapy. You can start that on the ward. All right, guys? All right. The high dose aspirin is not 21 days. It's aspirin with Plavix for a subset of people for 21 days. Minor stroke or TIA, you can treat them with 21 days with aspirin and Plavix, not high dose aspirin. You understand, Graham? The stroke practice is aspirin plus Plavix for TIA and minor stroke for a short course of 21 days. All right? In doubt, if you don't remember anything else from this lecture, remember this. Aspirin and Plavix, you do not treat patients with stroke for a long time with aspirin and Plavix. Point number one. Point number two, for secondary prevention for stroke, for all patients, they go home on low dose aspirin. Low dose aspirin, aspirin 81 as a thrombolytic therapy. If you want to change the patient from aspirin, you can give them Plavix 75. If you don't want to give aspirin, you can give Plavix, which is clopidogrel, 75 milligrams. And that's lifelong secondary prevention of stroke. This is core measure on discharge. If a patient has atrial fibrillation, they should receive anticoagulation because their CHA2DS2-VASc score is greater than 2. Anybody with a stroke, their CHA2DS2-VASc greater than 2, and so you automatically should get anticoagulation therapy. All right, so just for you guys to know that indication for AFib and stroke. Now, remember, we must investigate all patients for their etiology for why did they get a stroke. And the first thing you're going to do is put your hand on their pulse to look for AFib. All right, and everybody should know this. What is the pulse rhythm for AFib? What kind of rhythm you're looking for? After 21 days, Ryan, is a good question. After 21 days, you must continue stroke prevention with one agent, aspirin or Plavix. Aspirin or Plavix for greater than 21 days. Irregular, regular, them excellent, guys. You don't feel like they have a normal pulse. What you do next? Oh, everybody with a stroke must get an EKG. All right, I have a totally different lecture on that. I don't stress you guys too much on EKG and stroke. Here are the points. EKG and stroke, if you don't see AFib, you're not finished looking for AFib. The patient can go on a cardiac monitor or telemetry to look for AFib, and that's a 3-lead EKG. But if you don't see anything there, you don't stop there. You go on to 24 Holter to look for AFib. So technically, everybody who comes with a stroke must get a 24 Holter as an outpatient. Before they leave the ward, they should get an echo because you can get a thrombus in the ventricles that go up the carotids and cause a stroke. So that's why we do echoes. We can also get a bubble echo to look for PFO. Anybody knows what PFO is? Yes, Shika. That's why you must put everybody on a 24 Holter who have a stroke. Patent format of Valet, the only way you can pick it up is if you do a bubble echo. It's still a transthoracic echo, but you have to put bubble echo so that the technician introduces bubbles to see it go across the PFO. You won't see a PFO with a regular transthoracic echo. All right? There's a transthoracic echo. Please, it's a transthoracic echo for all stroke patients. And to get the best thorough echo is a bubble echo. All right. So this is a work to find out where did the clot come from. Everybody with stroke, we must find out that question. Where did the clot come from? All right. Now, everybody with stroke, we must look for our stroke risk factors. And one of them is called the lipid profile must be checked. And I already told you if the lipid is normal, we're still sending the patient home on statin. But also with lipid, we want to do a diabetes screen, and that's the HbA1c. HbA1c, that's what I usually use. Why you get 3 months worth of information with one little stick? All right. Remember, everybody who comes admitted to the ward with a stroke must have a dysphagia screen. We must make sure the patient is not an aspiration risk. And so you give them a cup of water to drink. If they're unable to drink, if they're mixing the water around in their mouth and not swallowing, if they cough and after they try to swallow, that patient is an aspiration risk and you put an NG in them. It doesn't matter if they're talking to you and look alert and obeys the commands. If they don't have a gag and they're unable to swallow, you put an NG in them because they will aspirate. All right, so correct. I forgot to mention the other part of stroke etiology workup. You can do carotid Doppler ultrasounds. No, be careful with the carotid Doppler ultrasound. If your stroke, the lesion on the CT brain is on the left side, and your high-grade stenosis is found by the carotid Doppler ultrasound on the right artery, it cannot be that is the culprit. So you have to make sure when you do the carotid Doppler ultrasound, the high-grade stenosis, which is usually greater than 80%, greater than 80% occlusion or narrowing of the carotid, it must be on the side of the stroke. So a right-sided carotid a narrowing with a left-sided infarct is not going to work. It is not the cause of that stroke. All right, just to let you know about that carotid Doppler ultrasound. It has to be on the side that has the stroke. All right. Remember, for stroke, I said transthoracic echo. Transthoracic echo, Bianca. All right. Another last thing that we do for stroke etiology workup is where is the athero? Where are atherosclerosis in this patient? Why they have a stroke? And the only way to find it is to do an angiogram of the intracranial vessels and a bit of the extracranial vessels. So everybody was the head and neck CT angiogram of the vessels to the head and neck. All right, and then you will know where the atherosclerosis is. All right. So that's the basic workup for stroke etiology. Back to ward. On the wards, remember, dysphagia screen gives them something to drink. All right. Remember, you look for stroke risk factors, lipid profile, diabetes screen. And everybody who has a stroke must know how to recognize another stroke because 1 in 4 stroke are actually recurrent strokes. 1 in 4 stroke is a recurrent stroke. So if you teach a person the first time around, control their risk factors, how to recognize a stroke, you can reduce morbidity and mortality. And remember, everybody must get speech rehab, limb physiotherapy with their stroke. Because up to 6 months after on rehabilitation physiotherapy, patients can get back their function. New brain cells take over the function and they get restoration of their function and reduce disability. All right, so please try and get people into rehab. At least they may not be able to afford outpatient rehab, but by the skills that they learn inpatient with the inpatient rehab person, they can continue it at home and get reduced disability. So please, guys, don't forget to refer all patients on day 1 to rehab. All right, any questions on the stroke core measures for ward management of patients and stroke management?
Hi, Doc. Just want to confirm that you're saying for all patients, for going home purposes, that we're going to give them all a high dose statin and we're going to give them the low dose aspirin, and this will be for life for secondary prevention of another stroke.
Exactly.
Okay.
Fantastic.
Thank
Correct.
you.
Thank you. Any other questions on what I've gone through so far?
Hi, Doc. The high dose statin is at 82. What's the dose?
High dose is 40 to 80 atorvastatin or 20 to 40 rovastatin. This section here. This section here, guys. Okay. Can you repeat which BP you give? Which BP you would give BP meds before 48 hours? If the patient is in the category of hypertensive emergency, which means end organ damage with BP is greater than 185 systolic, right? You can give IV bolus, titrating the blood pressure down no more than 20% of the original BP when they came in with. The hemorrhagic stroke, no more than 80 systolic blood pressure. So between a blood pressure of 180 systolic to 150 systolic is our goal for BP management on the ward for a hemorrhagic stroke. And closer to 150 as well.
Hi,
Right?
Doc.
If there is no end organ damage and the BP is greater than 180, you still want to control it. I would give a little titration because I want them less than 180, not too high. But that, as I said, you don't want to go to more than 20% of the reduction in the BP as well. Someone wanted to open their mic a while ago. Go ahead. Someone else.
I think you kind of answered my question. I was going to ask, I think the same thing that Marcelina asked, if the patient did not have any signs of end organ damage, but their blood pressure was greater than 180 systolic, then, well, I think you kind of answered that.
No. Remember though, you just want to give them a little bolus of a short-acting IV BP meds. And you want to recheck that with a short-acting, quick-acting drug. So you buy 15 minutes, you recheck, and you want the blood pressure between 180 and 150. Remember, the ideal situation is permissive hypertension. That's a systolic blood pressure greater than 150 or no greater than 180 within the first 24 to 48 hours. Right? Auto-regulation systems take in after 48 hours. All right, by 48 hours, the body itself should reduce the blood pressure to normal. Any other questions? All right, so let's review BP quickly. So for BP management in a stroke, permissive hypertension is the first thing you must always see. All right. If the patient has end organ damage with blood pressures that are greater than 180, then you give them a small titration of IV labetalol, IV nicardipine, right? Just give them a little bit to see the blood pressure come down in 15 minutes. If they have what we call now acute end organ damage, then you can consider infusion with the nicardipine, nitroglycerin, nitrosulfide. But guys, hydralazine is an option if there is nothing else. You can give hydralazine, but we hate it because it's really unpredictable. It will drop the blood pressure really quickly, really low, and it causes a reflex tachycardia. You don't. It's not a very good drug to titrate with. So that's why the others are better for us. And you can give IV ACE inhibitor. IV enalapril is a possibility as well. Don't tend to use it much because I didn't find it very, in my experience, very potent. But it's available in the ERs.
Excuse me, Doc. Is it possible for you to repeat the names of the ones you just mentioned?
Nicardipine, labetalol is my first choice. And you can, for persistent hypertension above 185, consider infusion with nitroglycerin or nitroclosamide. It's in the chat for the spelling. Also, remember with the nitroclosamide, you can get cyanide toxicity. So we tend to use the other three first.
Doc, and
Hi,
just
Doc. One
You
question.
know what, Ramdal? The guidelines on BP is still progressing. But in general, don't do 120. They come in that, but after you review them, let's say 4 hours later, or you admitting them 4 hours later on the ward and you see a 220, you don't let that stay. You don't let that stay. Because the higher it is, the higher they can hemorrhage. All right, so no, 220, no. All right, if it was 180, I said leave it in the first 24 hours, right? But not 220. Not 220.
Hi, Doc. Can you
Yeah.
repeat the situation in which you give the infusion with IV glycerin or nitrosamine?
If you say 220, over 150 or 115 or 120 diastolic, you can, but I prefer to start with a labetalol IV push or an enalapril push and see their response. Because most times they do respond and you get them between 180 with just these boluses. Do not like infusion as well because one, it's laborious to put up and it requires one-to-one nursing, very close nursing monitoring. We don't have that in Jamaica. We don't have it in Jamaica. So that's why I would say that's not my first choice. I would like to give a bolus and recheck. That's what I would prefer in Jamaican setting. We don't have
Hi,
that
Doc.
level of nursing. Yeah.
You give the bolus if there is no end organ damage. That's what you had said?
If the blood pressure is greater than 185 systolic, yes.
Okay. But if there is end organ damage, then it would be better to give the IV infusion.
No, you still start with a bolus.
Oh, you still okay?
Yeah, because as I said to you, infusions require intensive nursing monitoring, and we just don't have that in Jamaica. We just don't have it. So it's easily just to bolus them and say, nurse, check the BP in 15 minutes, I'm coming back in 20 minutes, and then come back in 20 minutes, and she's like, oh, the BP is so and so. Okay, let's give another IV push, and check in 15 minutes, and come back in 20 minutes, and she's like, oh, it's 180 now. It's like, all right, we're done here. Leave it as it is. Okay, that's what the setting would be like. But if it's like 220, 230, 240, don't let that stay. Give them a little something to bring them down to 180, please. Yeah, we're using 180 as our upper limit and 150 as our lower limit down. And as I said to you, the BP guidelines are kind of still in progression because right now there is no clear consensus. But they're saying that if you feel in practice to do the bolus, you can go ahead and do it. All right. But they haven't found an impact on mortality and morbidity by reducing the blood pressure. Right? I will give that disclaimer. The guidelines say there is no mortality or morbidity benefit, but I think it's especially if you're trying to reduce probability of hemorrhage, and in our setting where it's monitoring is not the best, it can go up higher, and then no one is monitoring it. When you know it's between 180 and 150, you're okay. You know where it is, and you've given something to keep it there already before. So, but then to just make it just go, you ain't come back 4 hours time, a patient's coning because the blood has just been pounding into the brain. Right? All right.
Hi, Doc. I have another question. We said that for the DVT prophylaxis for hemorrhagic strokes, we're going to give them the pneumatic compression.
Yep.
I wanted to know for the ischemic stroke, so do you do the same thing, or we're just depending that the aspirin would be sufficient, or would also give them some anticoagulation?
Remember, it's called DVT prophylaxis, and there are some molecules that we use for DVT prophylaxis. You can put it in the chat, anybody? What are they?
Like for heparins?
Yes. What kind of heparin you want to do? You're gonna put in the order now, Doc. What order you gonna order?
A low molecular weight heparin.
Yeah, man, but you can't put that on the nursing instruction.
You mean like what Bianca said you need?
Lower mercury, 5,000 units. Bianca, how are you gonna order the 5,000 unit? You have to put frequency. Remember, with every drug you put frequency, guys. Frequency, Bianca. Johnson, I want to know frequency. James, BD what? BD what, James? Sub-Q is the root. Sub-Q is the root. All right, Bianca, you want sub-Q, BD, heparin 5,000. The nurse will ask you, and you will say, yes, that's what I want. All right. For enoxaparin, which is also Lovenox, that is Johnson. What is that frequency? Johnson, what frequency you ended at? Did you write a frequency? OD, very good. So this is prophylactic dosage of low molecular weight enoxaparin and heparin. That's what we would normally use. There are others out there, some other low molecular weight heparins, some other molecules. But these are the often found on our wards and that we use commonly. Any other questions?
Just to confirm, even if the patient's lipids are normal, we're still sending them home on a high dose statin?
Oh, yes, we are.
Okay, thanks.
I mentioned the pleomorphic effect. The endothelial dysfunction is reduced with it. That's why. Endothelial are itchy and platelets get sticky, then you get clots. Permissive hypertension management is the same for hemorrhagic stroke as it's for ischemic stroke. Yes, Ryan. Right? After 24 hours, you start checking the BP more closely, and you probably want to give something after 48 hours. If they are not normal, you want to make them normal after 48 hours. Because they have to go home with normal BPs, guys. Yep, they have to go home with normal BPs. And make sure you give them a follow-up to a primary care physician, their health center, because stroke management requires primary care follow-up as well, okay? Any other questions? I'm gonna stop here.
Oh, yeah, yes, Doc. All right. So I just want to run through the thing just to make sure I've been following correctly. So they come in and we do our ATLS and we do our the NIHSS score, and then we do our non-contrast CT. And if they're within the first